good morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe. My name is Mitali Mistry, Senior Policy and Project Coordinator here at the IFA. And today I'm very excited to be introducing you all to Dr. Andrea Wershof Schwartz on the topic of age-friendly medical education. Dr. Andrea Wershof Schwartz is an Associate Professor of Medicine at Harvard Medical School, where she co-directs the geriatrics theme for medical students. Dr. Schwartz is a geriatrician at the Veterans Affairs Healthcare Center in Boston, Massachusetts, where she serves as Associate Director for Clinical Innovation in the New England Geriatric Research Education and Clinical Center. She also co-chairs the VA's National Steering Committee for Age-Friendly Health Systems Initiative, and Dr. Schwartz serves as faculty for the Institute for Healthcare Improvement and the Harvard T. Chan School of Public Health, and is also the editor of Strategies in Geriatric Medical Education. Thank you so much for joining us today, Dr. Schwartz.
Thank you so much for having me. I'm delighted to be here and nice to see everybody on the Zoom.
Absolutely. So I just want to get this conversation started and kind of ask you, what is the path that led you into the work that you do today? What has been your source of inspiration along the way?
Absolutely. Thank you for asking. Um, I'm sure, like many people on the Zoom, I was inspired by older people in my life. And as a child, was very close with my grandparents, and in particular, my maternal grandmother, who came to Canada from Poland on the eve of the Holocaust, leaving behind some family who did not survive. And I was very close with her as a child. And right around my 16th birthday, she reached the end of her life, but I was privileged to be with her during those moments. And I think of her often in my work as a geriatrician, because I think I'm really animated by this hope that everyone should have the privilege and the luck of living to old age in peace and in dignity. And certainly at this time of turmoil in the world, just that hope of people being able to reach old age in peace and dignity is such a beautiful image, and certainly inspires my work as a geriatrician.
No, it's great to see, what kind of led you into this work. And it's quite nice to have that kind of personal story in the back, that's there with you day to day, which is really nice. So as a leader in age-friendly health systems initiatives, could you describe what this actually might broadly entail?
Absolutely. So, the Age Friendly Health Systems Initiative was developed by the Institute for Healthcare Improvement with the support of the John A. Hartford Foundation and partnered with several hospital systems to develop what they call the 4 M's of age friendly care. And I'll ask perhaps Luana to share the link in the chat to the IHI's website around age friendly care. The 4M's summarize some of the principles of geriatric medicine and of best practices in the care of older adults. And for this audience that are regulars on the IFA Global Café, you may already be familiar with the 4M's, but you could probably even guess what they are because they really do summarize this area nicely. The 4M's are mobility, mentation, medications, and what matters. And this approach really takes these 4M's as a set to make sure that wherever older adults encounter the healthcare system, they're going to be asked about their mobility and function to make sure that they have the support they need to age in place or maintain their independence as desired, to lower the risk of falls and maintain their mobility, to do the things that matter to them. And fermentation, and in an age-friendly health system, older adults, mentation is assessed for both memory and mood, with a particular focus on dementia, delirium, and depression, making sure that these conditions or syndromes are detected and acted on in a way, again, that supports the older person doing more of what matters to them. For medications, in an age-friendly health system, uh, systems are built to identify potentially high-risk medications and make sure that medications are optimized in service of that 4th M of what matters most. So in an age-friendly health system, older people are asked about what matters to them, and then care is aligned with those goals. And so when the IHI launched age-friendly health systems in 2018, it really captured the passion of many within the geriatrics community, but even more importantly, beyond. I think really explaining clearly how to summarize some of the best practices that we've known for years can improve care for older adults, but really help implement those in a variety of health settings, whether in the hospital, in the clinic, in home care, in nursing homes, to make sure that the 4Ms are addressed for older adults in those places. And I got involved with the age-friendly movement about 5 years ago in my work as a geriatrician at the VA, at the Veterans Affairs Hospital. And I have been struck, and I'm sure we'll talk more about this, by how this initiative has really brought people together across different professions, across different care settings, to really be able to implement some of the things we know will improve the care of older adults. So I'm very excited about the Age-Friendly Health Systems Initiative potential to create a shared language for improving the care of us all as we age.
Oh, that's fantastic, and I love that the 4th M is, matters, like, what matters to them actually at the end of the day, like, everyone has a different kind of way of life and what they want, what their goals might be, and I think we've spoken previously with other guests about, what are older adults' goals? Sometimes it's just getting up in the morning and being able to brush their teeth. Other times it's being more active, things like that. So it's fantastic that this framework, exists and is expanding outside of, like the setting of a hospital, for example, but even, we learn from that and then it extends to other populations as well, other age groups, which is fantastic. Amazing. Could you take us through some of the most common health inequities that might be faced by the aging population within a healthcare system?
That's a great question and a very large topic, but I'll respond by naming a couple of the health inequities that we frequently see for older adults, and I'm sure many on this call are experienced with this personally or professionally. Um, I think the first one I'll name is ageism, and we know that in many societies, ageism is a very frequent form of both discrimination and perhaps stigma that influences the way people communicate across the lifespan. And ageism can result in health disparities for older adults in a number of ways. One is the idea of both undertreatment and overtreatment. An ageist approach might make assumptions about an older person's goals and desires for their healthcare encounter, and might lead to them not being offered necessary treatment uh, or being denied a treatment because of their overall health status without a goals of care conversation. But it could also lead to overtreatment if we don't appropriately ask and make sure that we've individualized care. And in an ageist approach, we risk missing important diagnoses. So, an example that I on Wednesday this week was working with the second year medical students, and we did a whole workshop on delirium, which many listeners may be familiar is a condition sometimes called acute brain failure. Delirium is a condition of confusion that affects hospitalized older adults. While it can affect people of all ages, it is very common in hospitalized older patients. And delirium is a state of acute confusion that can result from a stressor, whether that's an illness, a surgery, a new medication, or something else. And delirium is an example of a geriatric syndrome that can be prevented, that can be recognized and treated early, but can often be undiagnosed and missed, which can lead to very negative health outcomes for the hospitalized older person, including a higher risk of death, a higher risk of needing to go to a nursing home after the hospitalization, and in hospital complications such as falls. And so the reason why that sort of disparity may exist, where delirium, this life threatening condition, could be underrecognized, has to do both with a lack of education for health professionals in principles of geriatrics, as well as a lack of systems to recognize and address these disparities. So that's one of the things that excites me about being involved with the age-friendly movement, because it really does emphasize equitable care across the lifespan for older adults of all racial and gender and sexual orientation and religious, and et cetera, all backgrounds, recognizing that there's an overlap, there's an interaction, an intersection between ageism and other forms of discrimination. And so recognizing, setting up systems to detect disparities and be able to act on them and close them is really critical to ensure that person-centered care that we all want for our patients and our loved ones and ourselves as we age.
Amazing. Yeah, thank you for kind of taking us through that. It's important to understand kind of what challenges are faced by older adults just from the get-go. And, understanding that, we'll have a better idea of how to actually go about their care itself. So thank you for going through that with us. And so in order to, again, have these solutions to overcoming these inequities, there needs to be a certain level of change in our healthcare systems. Can you describe how the education of healthcare professionals might play into this systemic change?
Absolutely. So, health professions education is a key to beginning to change a culture or to implement new systems. And I recognize this is an international audience. I'm going to speak to my experience in the United States, but I would certainly be curious if folks want to mention in the chat other experiences in other countries. In the United States, I'm going to start by speaking about medical education for physicians. And in four-year medical schools in the United States, there are many requirements to have rotations, clinical rotations in certain clinical areas. So, for example, to be licensed as a medical school, every medical school is required to offer rotations in surgery, in neurology, in pediatrics. However, geriatrics is not one of those requirements. There is in the United States the Licensing Committee on Medical Education, which accredits medical schools, has a requirement that medical students learn about care across the lifespan and that they be exposed to issues around end of life care, around chronic disease management. So, of course, these are very relevant. But because there is no requirement for there to be a geriatrics rotation or clerkship or course, it's really left up to individual medical schools to enact how that will be taught. At the medical school that I attended at the Mount Sinai School of Medicine in New York, which has long been a leader in geriatrics education, every medical student had a month of geriatrics where they had opportunities to rotate on home visits in the hospital, visit a PACE program, which is a very unique setting that is almost like a outpatient nursing home, a sort of day center where people who could be living in nursing homes are able to stay at home. That month made a huge impression on me and affected my career choice, and got me curious as a professor about all the missed opportunities we have for our health profession students to learn about the exciting and interesting and meaningful field of geriatric medicine. There have been surveys of faculty over the decades that have shown that geriatricians, myself included, tend to love what we do and be very passionate and happy working in this field. However, we're a tiny field that really struggles to recruit and fill our fellowship slots. And so one of the studies that we conducted, and if you look in the chat, there is uh, an age-friendly teaching toolkit that's one of the links, and I'll just repost that. So the article I'm going to mention is posted there, and it really we studied the visibility of geriatrics in medical education. The paper is called "You Can't Be What You Can't See," and we looked at the websites of all the medical schools in the United States to see we could find on all of them their pediatrics rotation, which is very important and another population that needs special attention in the care of children. But we found that many medical schools, you couldn't find anything about the care of older adults specifically or geriatrics opportunities. And it led us to conduct subsequent surveys of medical school deans and medical school faculty to try to understand what's happening with the landscape of medical education. And our findings so far, led by my colleague, Dr. Katie Dawson, are that in the United States, because geriatrics is not a requirement, the dose of education on these important topics received by medical students varies widely between medical schools. While many medical schools offer an elective course, at most places, only a handful of students take advantage of that opportunity, maybe because they can't find it on the website. And so the result is that you've got many medical students who graduate and have received insufficient education in how to ask and address goals of care, how to notice high risk medications and come up with a safer plan for older patients, how to address delirium and dementia, as well as how to approach multimorbidity, the presence of multiple chronic conditions in older patients. And um, within medical education in geriatrics, uh, there is a lot of evidence to suggest that even small doses, when effectively done, can really help medical trainees, whatever field they're going into, take with them principles that will help them take better care of their older patients. And this trend is true in other health professions as well, where typically less than 1% in a given health profession specialize in geriatrics. But all health professionals need to have the basic skills to be able to skillfully care for older adults in whatever setting they encounter them. And this has been termed by Dr. Mary Tinetti of Yale, a previous guest on the cafe, as big G and little g geriatrics. That big G geriatrics are the folks who specialize in the care of older adults. And I bet we've got a few on this call as well. Uh, and, and little g geriatrics are the principles that the whole healthcare system needs to learn, needs to know, needs to put into action. So health professions education in geriatrics is necessary, but not sufficient to get us to an age-friendly health system. We need education for health professionals who are already practicing and didn't have this education during their training. And we need systems change that's focused on quality improvement and process improvement to make it easier for busy health professionals to do the right thing for their older patients. Because most of us, we all come to work wanting to do the right thing. And if we have systems in place and education in place that make it easier to do that, then everybody wins and the system itself can improve for us all.
Yeah, absolutely. You kind of put it right there for us, without the education itself, what are we going to do, right? You can't really just put out educated guess. You kind of have to have the tools and, the knowledge behind all of that. We actually have a comment here in our audience from Anna Maria. She says, I find it interesting that geriatrics is not a requirement in medical school in the US and perhaps in Canada. The reality is that these two countries have an increasing older population that requires proper healthcare and treatments for older adults. So it is whatever priority is of certain medical schools or even the government level, kind of what they're funding for all these medical schools as well, curriculum. But it is kind of all of our collective job to kind of push forward, the importance of care for older adults, as you mentioned earlier. So I think, yeah, thank you for that comment, Anna Maria. I don't know if you wanted to add anything to that, Dr. Schwartz.
Yeah, I'll respond to that. So I know that a wonderful Canadian group just published an article on academic medicine. I'm going to see if I can find it and put it in the chat that summarize the core competencies for medical students in geriatrics. And we've got a similar paper that's in the works on the American medical student competencies that were developed by the American Geriatric Society. And those are also listed in the teaching toolkit. But the article I just shared in the chat is a Canadian approach to taking the four M's, and they include the fifth M of multi-complexity, which is dealing with concepts of frailty and of multimorbidity, of social determinants of health. And they really laid out what every medical student in Canada should know. So we've got a similar paper coming about the American competencies, and I'll share, so the paper's not out yet, I'll share those competencies in the chat. You'll see they very much align, and they really get at the idea that whatever field a doctor is going to go into, we really want to make sure that they have these key clinical skills to take care of older adults.
Yeah, that's fantastic. Oh, bless you. And
Thank
thank you so much for sharing those articles, right in line with that as well. And I actually just wanted to jump back to, there's another question just at the beginning, just as we kind of passed through the conversation on inequities. I was wondering if you could answer a question here from Shmuel, who asks, based on this type of age-friendly education, I guess what are the considerations for older adults coming from maybe a lower economic socioeconomic status?
Absolutely. Thank you for that wonderful question, Shmuel. Um, Certainly, we know that the social determinants of health from even in utero and certainly in early childhood can affect people for their entire life. And so, whether that's access to healthcare, education, safe housing, nutrition, the foundation is set during the early years. Um, However, it would be ageist to say, oh, well, someone's path is set and there's nothing we can do. And we know that there are so many things that we can do, both to mitigate the impact of low socioeconomic status, low health literacy as people age. But in particular, we need to make sure that we're delivering age friendly care in an equitable way. And there are a few different ways that age-friendly education can make sure that care is delivered equitably. The first is to really name and explore those inequities, to make sure that patient-facing information is available at multiple levels of health literacy. Uh, I'll give a very practical example. In my own clinic, when we print out our patient instructions, we print them out in 16-point font, which is quite large. I've never had anyone be upset by that, but I've had many people thank us for the large font. And it's the classic example of curb cuts on the sidewalk, which were initially advocated for by disability rights advocates. But curb cuts on the sidewalk benefit anyone pushing a stroller, riding a bike, and so it's this idea of making a change that can benefit one population can ultimately benefit everyone. So, for example, making sure that health information is available for people with lower levels of literacy, for people who speak different languages than the language spoken by the majority, making sure that there is guidance available for older adults who are of lower socioeconomic status, making sure that resources are available. That can make a tremendous difference in someone's health outcomes. Um, we often talk about how interventions like Meals on Wheels, which is called different things in different places, but is often a taxpayer funded but volunteer led initiative to bring meals to older adults who may have difficulty leaving their home or difficulty preparing meals. And that's an example of an initiative that both brings a needed resource, nutrition, but in many settings also brings needed social connection and can be a vehicle to provide information about how to access other resources. Um, what I like to say is that for the care of older adults to truly be age friendly, there ought to be no wrong door. There ought to be no entry point to the healthcare system that doesn't know how to point someone in the right direction. And this idea I thought about based on an experience I had working at the VA hospital where I work, where I actually got onto an elevator with an older veteran, and we rode up the elevator together. And he offered to press the button for me because he was standing closer to the elevator buttons. And he asked what floor I worked on. And when I told him, he said, "Oh, what's on that floor?" I said, "Geriatrics." And he made a joke. He said, "Well, I need geriatrics. I don't even remember what floor I'm going to." And we joked a little bit. And when we got to his floor and the door opened, I watched him get off the elevator and go to his appointment. And I noticed that his walking was pretty unsteady. His gait was as quite unsteady. And so I kind of stuck my head up, make sure he got in the door okay. But as the elevator doors closed, I really thought about uh, which clinician was he going to see? Were they going to have the training in age-friendly care in the 4Ms to be able to recognize his memory problems, his mobility challenges? And I imagine maybe he was going to see the eye doctor. Well, I wouldn't necessarily expect, it's not within the eye doctor's scope necessarily to diagnose any memory problems or mobility problems. But the idea of there being no wrong door is that if the eye doctor notices the memory problems, maybe they would contact the primary care doctor or recommend that the patient get in touch, and really try to help connect the patient with the resources of the healthcare system wherever they encounter it. So I think to your wonderful question, Shmuel, of how age-friendly education can support a more equitable system, I think it's really that no wrong door approach, making sure that every health professional can recognize warning signs of dementia and know how to connect someone with the appropriate resources to get the care that they need, for example. So thank you for that wonderful question.
Yeah, definitely, truly, having that level of interconnectedness amongst healthcare professionals is so essential. Like everyone has their specialty and their ways of going about understanding, diagnosing, treatment. So it's great to have that that huge network of support with the different level of care that's required. I actually just wanted to move to another question here and kind of ask you, what does a typical age-friendly framework, what might that look like for a healthcare system looking to implement this particular care for older adults? And you might have already touched on some of these bits as
No,
well.
I'm very excited to answer this question because this is a lot of the work that I do with the Institute for Healthcare Improvement and with the VA is helping teams implement age-friendly care. And so I'll begin by saying that, um, again, age-friendly care is focused on the 4Ms: mobility, mentation, medications, and what matters. By the end of the call, you'll all be able to say it. And it really takes a quality improvement approach, which is really treating our healthcare as a learning health system, where we try something, we study it, and we see if it worked, and then we tweak it and keep studying it so that we can make sure that the changes we make are actually having positive impacts that we want in older adults. Now, the 4Ms were developed on a very robust evidence base, uh, but that one primarily looked at each M individually. There's a great evidence base for how to prevent delirium and mitigate it. There's a great evidence base for addressing polypharmacy, et cetera. But the 4Ms as a set is new and is a really exciting innovation and was drawn from research led by IHI that looked at many different evidence-based models of care and tried to find what were the common denominators that led to successful care. So for a health system that is looking to implement the 4Ms, there's actually a lot of guidance available. And the first place I usually point people to is the IHI's website that really details the principles of age-friendly and has resources to help teams that are interested in implementing. So the IHI actually runs action communities, which are a series of webinars and coaching calls to help teams implement age-friendly care, and I serve as faculty on these action communities. We run an action community in the VA. We just concluded one with 400 healthcare teams from around the country, all different settings. So what do we do with these teams? I'm going to try to summarize, a 7-month action community in a couple of minutes, but hopefully the listeners will find it helpful. The first thing we do is we ask teams to think about, in your care setting, what do you already do in each of the 4Ms? Are you already assessing mood or memory? Are you already looking for any issues with mobility or function? Are you already asking older adults what matters to them? Maybe you're asking about advanced directives or wishes regarding life-sustaining treatments. So what are you already doing? And then the next question is, are you doing it reliably? Is this something that just happens on an ad hoc basis, or does every older adult have their medications reviewed on an annual basis or with a change in status? Do you have team members who are the point people, the champions for each M, who are paying attention to what is our falls rate in our nursing home? That's required to be reported, but are we looking at what seems to make a difference and how can we get things going in the right direction? Then we encourage teams to build on what they're already doing. And that might be an M where they're already quite strong, making sure it's more reliable and equitable and that every older adult is getting that care. Or it may be an M where they're not currently evaluating patients. And so maybe there isn't a mobility assessment going on. And so there's an opportunity to try out and see which evidence based mobility assessment could potentially fit into a clinic's workflow, into a hospital workflow. And I'll share a video that we developed to help teams learn about the different mobility assessment tools. So once teams have recognized what they're already doing, looked for opportunities for improvement, we then encourage them to use quality improvement techniques such as PDSA cycles, plan, do, study, act, where teams will try something, study it, see how it worked, and then carry on to the next iteration. And doing multiple PDSA cycles will allow teams to figure out what is the best way to integrate the 4Ms. Are we going to put it in our team huddles? Are we going to put it in our note templates? Are we going to track it in our monthly trackers or our daily trackers? And I'll share one exciting example from our clinical team where we just published this, and it's one of the papers that I shared, and I'll just copy it back into the chat. Our VA nursing home decided to implement age friendly, and we took about a year to build an interprofessional team, to teach all of our team members about the 4Ms, to update some of our workflows, our team huddles, our note templates, and to really look at ways that we could improve the care of older veterans living in the nursing home. Then what we did was we studied the year before age friendly to the year after age friendly. And we were thrilled to see that there were major decreases in falls, about 33%. We track something called disruptive behavior reports, which is not a very person centered term, but this refers to a person living with dementia who may be distressed and be acting out that distress. And we had a 2/3 reduction in those types of behaviors, which meant that patients were happier, the staff was dealing with less burnout. We had fewer admissions to the hospital and the emergency department. And the most amazing thing about our age friendly transformation, which was led by my colleagues, Dr. Marcus Rope and Dr. Sarah King, and a whole interprofessional team that's listed on the paper, was we really saw the impact of the synergy of the different initiatives, one on medications and one on falls and one on asking about what matters called My Life, My Story. Bringing these all together under the 4Ms umbrella had a synergistic effect. It helped the team be more unified, and it helped make sure that our patients were getting 4Ms age-friendly care. So this is just one example, and this is from a team that's now been doing this for several years. But certainly, when teams want to implement age-friendly, we encourage them to start small, start with what's already going well, focus on the bright spots, and just keep making incremental progress and build partnerships with other teams that can help you, with other teams that have done this. So my biggest advice would be just not to reinvent the wheel, because now there are thousands of teams all over the world implementing the 4Ms of age friendly, and many other teams that are doing similar work but isn't called by that name. And so learn from colleagues that are doing this work, reach out to us either at IHI or in other teams that are leading age-friendly work, such as the American Geriatric Society, the American Hospital Association, and there are other international partners as well. And so I think because there is so much good work to be done, learning from one another and building on one another's work is part of the necessary ingredients to really spread this culture change and this shared language across our healthcare system.
Yeah, thank you so much for that. That was an incredible wealth of information just there in that one answer. You know, I really love the fact that you're integrating, um, the understanding that yes, we can actually lean on each other's. There's all of this research, this, work being done. We might as well take advantage of it and kind of spread it and integrate it into our systems as much as possible and just communicate with each other and say, you know what, this is working really well. Like maybe this is something you can do, or, ask each other. There's never any shame when there's something incredible such as this kind of initiative happening, might as well use it, right? I'm just gonna, there's a lot of comments and questions in the chat right now. So again, if anyone has questions or comments that they want to address to Dr. Schwartz, please put them in the chat. I'm gonna start going through some of the ones that I haven't already gone through. I think right now there's a comment here, or question here from Peter Whitehouse. So I think he has a kind of a concern of like, how do you kind of integrate the concept of more of like a life course approach within geriatric care? I think what he's talking about intergenerational relationships, things like even the climate crisis, all these external, but, very much related to kind of what we're going through.
Absolutely, such a wonderful question, and one that's very close to my heart. So we talk about caring for older adults across the health span, and the health span, of course, refers to the heterogeneity of aging. That we know that, as Dr. Louise Aronson beautifully writes in her book Elderhood, that the period of time we call old age can span half a century, right? It could span from age 55, when people in the United States start getting their AARP membership cards, to the Association for Retired Persons, maybe even age 50, they start getting them, um, all the way to a centenarian or beyond. And so this huge span of our lives that we call old age is so varied and has so many different stages within it, so many different life milestones that can look different for each of us as we age. And and so what we really need to make sure is that our care for older adults includes a focus on healthy aging, and for older adults that are at the peak of their careers, and we want to make sure that our healthcare is supporting those goals. And for older adults who may be very frail, maybe living with dementia, maybe dependent on 24-hour care, our healthcare system needs to be there and deliver compassionate care. So really across that health span of old age. And I love that this question speaks to intergenerational connections, because your very first question to me, Mitali, was what inspired me to go into the field. I mentioned my grandparents, and I'm sure many of us on the call, those intergenerational relationships are so precious and so meaningful. We recently launched a program at Harvard Medical School, where I teach, where we matched our first year medical students with older alumni of the medical school. So people who had graduated at least 40 years earlier than the current students. So they're all age 65 and above. And we had a tremendous response from our alumni, and we recruited mentors ranging in age from 65 to almost 100. And the students and the alumni mentors will have a series of calls where they'll have an opportunity to talk about how medicine has changed over the course of the mentor's career, talk about questions of aging and ageism, and really give the students an opportunity to form that meaningful intergenerational connection. And this is building on decades of work looking at the impact of intergenerational programming, whether it's Seniors as Mentors programs, whether it's the intergenerational programs that sprung up during COVID as a response to the social isolation and loneliness imposed by the restrictions of the pandemic. And these intergenerational connections are so critical and really mutually beneficial, because an older adult has the opportunity to share their wisdom and life experience with a younger person, and a younger person has the opportunity to learn from someone who's lived in a different generation, in a different era. So I do think that these intergenerational programs can be incredibly meaningful and impactful, and can really set a foundation for a healthcare system that delivers for all of us across the lifespan and across the health span.
Absolutely. Thank you for mentioning that. It's incredibly important for us all to consider, we're starting at this point here, but we're gonna make it to over here. So we really need to consider the full range, the full spectrum of everything, and keep that in mind as we go through our lives, not just in terms of health, but kind of everything, everything is connected in one way or another. I also like that in the comment section, Roni has kind of added to the four M's. They've added malnutrition, main caregiver, things like that. So I think it's important for I think everyone to just keep on thinking of things that are really important to them. As you mentioned, what matters, right? And at the end of the day, you have some of those main parts over there, but it can go beyond that, depending on what you really need. And then Jane Carmody kind of inserted, yeah, a recent survey where 96% of US medical schools require a pediatrics rotation, and right now 10% require geriatrics, as Dr. Schwartz has noted earlier. So again, we're really hoping that kind of, changes, hopefully we get a little bit more of that integration into our systems. And then we had Dominic Boyd who shared an article on frailty. If you wanted to talk about frailty a little bit in kind of the context of medical education.
Yeah, absolutely. So, one of the hats that I wear at the Harvard School of Public Health is I co-direct a course that we run on frailty, and the course really asks the question: what is frailty? How do we identify it? And how can we mitigate it? And so, the concept of frailty is really this idea that there is limited resilience as we age to the stressors that life throws our way. And so the example that we like to give is, if a fit older person, for example, gets COVID, they might get quite sick from COVID, but they'd have a much better chance of bouncing back to their prior level of function. If a frail older person gets COVID or some other infection, they have a much bigger risk that this stressor might stress their body systems and lead to severe illness, hospitalization, and a longer and more difficult recovery, and of course, a higher risk of death. Now, there's a spectrum of frailty, and frailty is dynamic. It's not a one-way street. So while frailty increases with age, we know that frailty is multifactorial, and the development of frailty seems to be able to be very affected by exercise, nutrition, cognitive engagement, the four M's, if you think about it. Um, but one of the challenges in frailty is how do we measure it? And our team recently launched a website that I just put in the chat called eFrailty that is actually meant for clinicians to know which frailty assessment tool to use in different settings, because measuring frailty for someone who's about to undergo surgery is quite different than measuring frailty, say, in my geriatrics clinic, where we've got a pharmacist and a social worker and a nurse and a doctor all working together to do a comprehensive assessment. What those frailty assessments have in common is that when we can identify frailty, we have the opportunity to mitigate it. We have the opportunity to recognize, this person seems to be slowing down. They have a slow gait speed. They're having more difficulty bouncing back from health stressors. What can we do to mitigate their frailty and strengthen them? Maybe a round of physical therapy or meeting with a nutritionist, maybe addressing hearing or vision impairment, maybe optimizing the medication list. Could any of these things help mitigate the frailty so that that person can be more resilient to stressors? And if across the frailty spectrum, we need to be asking what are the goals and the healthcare goals and the priorities of the person that we're treating, because different people living with frailty may have different approaches to what sort of healthcare they're willing to go through. And we need to ask, because it's the patient who's the expert on what their goals are. And it's the clinician who can be the expert in recommending which treatments or pathways can help support those goals. So frailty is a really important concept. And it really gets to the idea that as a system, we need to be supporting older adults across the full health span of aging, from fit to frail and everything in between.
Yeah, absolutely. Thank you so much. And thank you so much, Dominic, for sharing that article as well. That's in the chat. Sorry about that. And so we have a comment, or actually a question here from Darlene as well. And she's kind of asking a kind of a different take on everything. And can you speak to the system policies that might be barriers to the treatment of older adults? And she puts the example of hospital delirium as an example. And kind of how can we start advocating for changes to these policies?
That's a wonderful question. And I know we've got an international audience today, so I'm sure things are different in different countries. I know where I sit in the United States and within the Veterans Affairs healthcare system, there's a really big emphasis on transitions of care and communication across transitions of care, because that's an area of major challenge particularly for an older person who's dealing with hospital delirium and may not be able to advocate for themselves in that moment, or somebody living with dementia who may be disoriented and unable to advocate for themselves in the hospital. So those are particularly vulnerable patients where we really need strong systems in place to make sure that their healthcare proxy or surrogate decision maker is engaged, to make sure that all the team members are aware that this person may be cognitively impaired, um, to make sure that their wishes can be followed. Um, and there can often be system barriers in place when there aren't systems to recognize delirium and flag it. Darlene, you bring up the issue of um, trying to transition people, say, from the hospital to a rehab or nursing home, and a nursing home not wanting to accept someone who's demonstrating perhaps distressed behaviors requiring one-on-one supervision. One of the things we tried in our own hospital was creating an age-friendly toolbox, which is a physical set of drawers that has tools that were approved by our infection control and our patient safety officers that can be used by patients that may help decrease some of these distress behaviors. Some things are very practical, like pocket talkers or pocket amplifiers that can help for someone with hearing impairment that either doesn't have or has lost their hearing aids, which unfortunately is not an uncommon occurrence when someone's rushing to the emergency room, and that can increase their ability to communicate with their team. Uh, some of the other practical things are things to engage the mind while sitting, waiting in the hospital for a test or a procedure, things like puzzles or um, other cognitive engagement things for people across the cognitive spectrum and literacy spectrum. And one of the things we found is that our nursing team that helped design these toolboxes uh, were able to be much more creative with helping figure out what an older person might need to help them emerge from being distressed, making sure their needs are met, whether that's pain or constipation, or reorientation, or a visit or a video call from a loved one that could help reorient them. Another program that we integrated, which was developed at the Durham VA in North Carolina, is the STRIDE program, which is an inpatient mobility program where a nurse or physical therapy assistant walks hospitalized patients a couple of times a day. And just that one intervention seemed to be associated with decreased delirium and increased discharges to home. And so you can really see the synergy between the four M's, that dealing with the delirium, the mobility can really have a positive impact. And so I would say one of the most positive developments I've noticed as a geriatrician since the four M's and age friendly started to become more common is that we now have a shared language across these care transitions that can help us do them more smoothly, can make sure that a person's baseline cognition and mobility is noted across a care transition so that when someone shows up in a rehab and they don't know where they are, but there's documentation or a warm handoff that says, no, they were cognitively fine on discharge, that rehab can then notice maybe there's delirium going on. We need to act on that. So I think that there's an opportunity to improve our transitions of care by advocating for policies that make sure that these key principles are assessed and acted on at every care transition.
Absolutely. And thank you, Darlene, for posing that question. Thank you, Dr. Schwartz, for kind of addressing all that. So, it's really important to kind of have that and that knowledge for sure. I actually wanted to go to a question from Dilek. I know you posted a link to an article already there, Dr. Schwartz, but I wanted to actually kind of understand that a little bit more, the integration of public health science and kind of how that works in terms of implementing that into age-friendly medical education.
Absolutely. So when we talk about public health systems, we're really, the analogy we often use in public health is that if there's a river where people are falling into the river, um, medicine is what's rescuing people from the river, but public health is, building a fence and putting up signs so people stop falling into a river. Now we need both. We can't ignore the people who are already in the river, But if we don't go upstream and figure out why are they falling into the river, we miss an opportunity to prevent tragedy in that analogy. So age-friendly public health is about setting up systems in addition to our healthcare system itself to really support us all as we age. And I did share an article in the chat about an age-friendly approach to public health. And it really speaks to the idea that everything from the physical architecture of our cities to the accessibility of programs can make a difference in our public health approach. So I'll give a couple of examples. I live in Boston, Massachusetts, and we've got an age-friendly Boston approach that's run by the city. And I noticed over the pandemic these age-friendly benches popping up. And these were benches put on long stretches of sidewalk so that if you're out for a walk and you get tired, you can have a seat. Well, that's of course good for an older person who may be frail and walk with a walker, but that's also good for people with little kids or people who, tore their ACL playing ultimate frisbee. So again, that age-friendly approach is that's why I love the term age-friendly, because it really speaks to being across the age span. It's not just things that are good for older adults can be good for everyone. So the age-friendly benches is a nice visible example, but certainly making sure that our public health systems are accessible to people of all ages, of all levels of literacy, different languages. We saw this particularly during COVID, and making sure that people have the information they need to access important and life-saving vaccinations. And then, where are your vaccination stations located? Are they accessible for people with mobility limitations? And so that sort of approach in a public health mindset is critical for making sure that the needs of older adults across the health span from fit to frail are really taken into account when both healthcare systems and public health systems are planning. So we talk about an age-friendly ecosystem, and this is the idea that these approaches, a person-centered approach to the care of older adults, really needs to permeate all aspects of our ecosystem to really help us all be able to thrive as we age.
Oh my God, that was great. Thank you for that analogy in the beginning of, describing kind of like what public health is in regards to, overall care as well. We need all that together to come into play. And again, love that you mentioned again, the fact that it's age friendly means it's again for all ages, really. So thank you for going through that. And then I think we still have about 6 minutes, so I do want to address, there's a lot of good stuff in here, so I want to address, I think there's one more question from Dr. Rao. I think she just wanted to know, I think specifically kind of in the medical education that you might provide, are there like sessions or courses for students specifically in terms of nurturing their sensitivity towards older adults, perhaps, empathy, things like that?
Absolutely. Yeah. Thank you for that question. So, the way we've integrated geriatrics education at Harvard Medical School is using a technique called spaced learning. And that means we give sort of doses of education across the medical students' education using scaffolding that helps them link the different episodes. So, we give our students a pocket card about age-friendly care that was designed by one of our students and is on that age-friendly toolkit link. And so they have a physical reminder of these key principles. And we go each time we remind them about the overall 4M's principles. We also teach the 5th M of multi-complexity. And we draw a lot on the work of the John A. Hartford Foundation. I want to recognize that Jane Carmody is here. And the John A. Hartford Foundation, which has supported the development of IHI and supported many other geriatrics education initiatives across the years. Really actually helped me get my start in developing a medical education curriculum for our geriatrics fellows at one of the Hartford Centers of Excellence. I want to acknowledge and thank that generous support. And so with our medical students, what we do to try to build empathy and connection is a couple of things. One is the alumni mentoring program that I mentioned, where our students are being matched with an older medical school alumnus, and that program will be starting this year as an opportunity to really connect across generations. But just this past Wednesday, we brought our second-year medical students to a home visit with an older adult, where they went in groups of 2 or 3 with a geriatrician or geriatrics fellow and visited with a volunteer living in an independent living facility, and have the opportunity to ask them about their life, to visit in their home, and also an opportunity to practice asking some of the questions that are part of a geriatric assessment. And this program has been running for many years. We've published about it on our Age Friendly Toolkit. And one of the things that we love reading in the students' reflections is, this is the first time I got to interact with an older person who, wasn't my grandparent, wasn't my professor, and really just ask them about their life and really connect with them. We also have a program at our VA called My Life, My Story, where our trainees interview an older person about their life and write up their story. And the patient gets a copy, and with their permission, it goes in the chat. It goes in the chart, so that everyone taking care of the patient can know more about their life. I just had a patient in clinic yesterday who had a beautiful My Life, My Story that I got to read before I met the patient. And then it was easier for me to engage and connect with him. And the trainees on my team were able to as well. So I'll share that link in the chat. So those are just some examples of the ways we try to encourage our young trainees in particular to connect with their older patients as people, and to approach their care with empathy and with compassion, and to really use their imagination to think about what kind of care do I want for my grandparents, my parents, myself as I age, and really hope that that helps usher in a change where our healthcare system is truly able to deliver that age-friendly, person-centered care for us all as we age.
Yeah, that was really lovely, and thank you for sharing that link over there. My story. I think that's all incredible tools, to have at the get-go with medical school students from the get-go, and then also just tools that healthcare professionals, doesn't matter kind of where along the line they are in their clinics, their years of working. I think everyone can kind of use a little bit of empathy. So thank you, Dr. Rao, for posing that question. Thank you, Dr. Schwartz, as well for going through that. I know we only have 2 minutes left until the end of the hour. It went by really quickly. There's so much information and great questions and great comments, and a lot of great resources that have been posted in the chat by Dr. Schwartz, as well as a lot of our participants. But now that we are slowly coming close to the end of today's Global Cafe, and before we wrap up, I would love to hear your key takeaways from today's discussion. So I'll give you a few seconds to gather some of your thoughts, as I'll introduce our next week's topic and speaker right now. All right, and so please join our discussion next week with Dr. Varshini Varadaraj on the topic of aging with vision loss, and improving access to care, which is ahead of World Sight Day that is taking place on 10th of October. So please join us to listen to that great discussion happening next week. All right, so Dr. Schwartz, we'd love to hear some of your key takeaways from today's discussion.
Thank you so much, Mitali, and thank you all for this wonderful discussion. I think some key takeaways for me are that we all need to be advocating for age-friendly health professions education, age-friendly health systems, age-friendly public health, and the ways we can do that are by sharing what works, sharing those success stories, sharing our experiences as in our professional or personal lives, so that we can continue to advocate for the support that's needed to really transform our education system and our health system to provide excellent care for us all as we age. So it's really been a joy getting to chat with all of you today, and I'm certainly happy to continue the conversation. It's something I'm so passionate about, and really privileged to be part of an incredible team that is devoted to this work. So thank you for having me today.
Absolutely. Thank you for joining us. And again, thank you so much. Before we sign off, I would also like to, again, thank everyone for another great week of our Global Cafe sessions.
Yeah.
Again, special thanks to Dr. Andrea Schwartz for joining us today. And great thanks also to the incredible people working at the IFA who have supported this and every other Global Cafe, in particular, Miss Luana Colnago. So thank you, everyone. We hope to see you all next Friday and wish everyone a great weekend. So take care.